Chapter 19 concerns the thorax and lungs. Some of the anatomical things we're going to be looking at include the thoracic cage, which is formed by the sternum, the two scapulae, the ribs, and the vertebrae. And this forms a cage, if you will, and also the muscles and cartilage that are attached to those bones as well. And in each space between the ribs, there's also a nerve, an artery, a vein, and capillaries, and many other structures as well. The sternum has three parts. The manubrium is the top part, then the body, and then the xiphoid process is the bottom part of the sternum. The clavicles, two of them just above the ribs, and then the suprasternal notch is a notch that at the top of the sternum, and then following that to where you'll follow that, there's like a groove where called the angle of Louis, and that's an important landmark. That's going to be where that's going to point the second intercostal space, which is something that's going to be important to you, particularly when we get to the chapter on the heart. Each rib is numbered so that and there's an intercostal space that's the one just below that rib, so that the first intercostal space is just below the first rib, and etc. The costal angle is visible from ribs 7 through 10 anteriorly, and it is the upside down V formed by the rib cage, and that becomes important because that can be that can be changed in particularly in COPD and diseases like COPD. Then we also use some imaginary lines to define where things are. And those lines would be the mid-sternal, which goes straight down the sternum. There's only one of those. But then there's two mid-clavicular lines, a right and a left. And then there's two mid-axillary lines as well, a right and a left, and then there's also two anterior axillary, two posterior axillaries. Then there's only one vertebral line, that's the one that corresponds to mid-sternal on the back, but there's two scapular lines, the right and the left scapular line. So we're going to use those imaginary lines to define, particularly like if you find something and you want to chart where you found it, why you'll use those lines to define it, and also we'll use it also in order to define where you're going to be auscultating, where you might find certain landmarks, that kind of thing. So then the thoracic cavity contains the mediastinum and the lungs, and then the mediastinum contains the trachea, bronchi, esophagus, heart, and great vessels. And then the lining on outside of this thoracic all the mediastinum and lungs, there's a lining outside of that. It's the visceral pleura, And then there's also the parietal pleura. The visceral pleura is on the side of the organs. Parietal pleura is on the side of the thoracic cage itself. And between these two pleura is the pleural space. But normally that is only a virtual space. It doesn't actually exist. The pleura are very close together. There is a small amount of pleural fluid in there that lubricates the two pleura, and they just slide with each other, and there's really no space there. But under abnormal conditions, there can be a space in there. So turning to the mediastinum again, the trachea should be midline. It shouldn't deviate to the right or the left, but sometimes you will see it, and that's one of the things to assess for. And then we have a right and left main bronchi. So then these there's a difference in the configuration of those, in that the right main bronchi is bronchus is straighter than the left, so that has implications for where things are likely to go when you aspirate and things like that. The idea of dead space is, think about, to explain what dead space is. It would include the trachea, the bronchi, and these passages. And think if you were at the bottom of a swimming pool and you had a garden hose and you were trying to breathe in and out through the garden hose. Well, you probably, maybe if you went swimming, you probably had a short tube that you were able to breathe in and out from, and there was no problem. But if you exhaled into, say, this garden hose, why, you would quickly get in trouble, because you'd be exhaling this carbon dioxide and then inhaling the same carbon dioxide. And the bronchi, the trachea, all these structures, there's no there's no gas exchange taking place, so that is what we call dead space. And if you have a ventilator tube on a patient in a hospital, why, that ventilator tube is also dead space. And sometimes, for example, if the patient's CO2 level is too low, the physician may order, well, just increase the dead space. So you would put more tubing on and have them exhaling into that dead space tubing, and that many times will solve the problem. Bronchioles are divisions of the bronchi. There are further subdivisions where the air is distributed. And then the alveoli is where the gas exchange actually takes place. Obviously, unless we're doing a bronchoscopy, we're not going to see any of these structures. Or, outside of the anatomy lab, we won't see any of these structures. But we do indirectly assess them. The apex of the lung is the peak, at the top. It's a dome shaped, or not a dome, like a mitre, like a bishop in chess, mitre shaped structure at the top. And then the base is the structure at the bottom of the lung, and that's totally opposite to the heart. When we get to the heart, you'll see that the apex of the heart is inferior and the base is superior. And thinking about the heart, the pointed aspect of the heart is going downward, and the flat relatively flat part is at the top. So that makes sense when we think about it in that way. But if you're not careful, you may mistake those on a test or something. The lungs will go from anteriorly. There's a small portion of the lung that is above the clavicles in what we call the supraclavicular space, and then they'll extend down to about the sixth rib. Uh, and this is going to depend also on whether you're inhaling or exhaling. The diaphragm goes up and down, as we'll see, and it also depends on if your lungs are maybe hyper expanded from disease or something like that too. Posteriorly, they'll go from the C7, which is about C7, which if you bend forward, there's like a lump in the back of your neck, and that lump is C7 to about T10 normally. The diaphragm is the primary engine, if you will, for breathing. Under normal circumstances, the diaphragm ascends and descends, and that's the normal. Now, there are disease conditions such as COPD where you may use accessory muscles like the intercostal muscles and such, but normally the diaphragm is the main for the main force that helps us to breathe. So breathing occurs when the chest expands and contracts. The diaphragm goes down, chest expands, and that creates a negative pressure, and air is going to rush in. And then expiration is mostly passive, where the muscles involved relax and the air just goes out. The breathing is controlled in the brainstem mainly. The medulla and the pons in the brainstem control it, but there's also regulation from the hypothalamus and from the sympathetic nervous system. When you get a hormonal, perhaps regulation from the hypothalamus, or when you get a stress situation that activates the sympathetic nervous system, why then your breathing increases, that you're in the fight or flight mode, and so it's quite common for your breathing to increase. And if it's a physical stress, like say a big dog is chasing you, why that's going to help you to run away. But many times in our modern life, why our sympathetic nervous system gets activated when it's not a flight or fight situation. Maybe your boss or your professor or somebody starts scowling at you, and you think, oh no, it's coming, and you start stressing, and you can't run. You'd like to, but you really can't. And you can't fight either. You'd probably like to do that, but you can't. And so you're stuck with all this sympathetic nervous system stimulation, and you're hyperventilating. And there's not any physiological, we'll talk about hyperventilating later on when we get to breathing patterns. Some of the things that regulate breathing, or that drive this regulation, the most powerful one is changes in the CO2 level, normally, under normal circumstances. And CO2, basically, it's not an acid in itself, but in the body it becomes an acid. In the bloodstream it becomes carbonic acid, And so that decreases your pH. When you get more acid, your pH decreases. And so that is the most powerful trigger to increase the respiratory rate and depth. And what that does is it lowers the increased respiration, lowers the CO2. Uh, so that will, and then that restores us to homeostasis. There is a secondary drive to breathe, which is triggered by a decrease in oxygen saturation. Normally, that's less powerful, but some people become accustomed to high levels of CO2 and they basically suppress that CO2 drive to breathe, so they become dependent on this other hypoxic, what we call the hypoxic drive to breathe. And that frequently that will occur in COPD and diseases similar to COPD sometimes. But normally we have both of those two drives to breathe, but the drive from increased CO2 is the more powerful one. So, as always, we begin our questioning with the history of the present concern. So, this kind of assumes that the person came to you with some sort of breathing problem or that they expressed some sort of breathing problem. And it could be dyspnea, which would be difficult or painful breathing. Or maybe they would have chest pain, and you would want to do whatever the symptom was that they came to you, you would want to do cold spa on it. Or maybe they are complaining of a cough, and sometimes they may come complaining of GI symptoms because we know that, for example, sometimes chest pain gets misinterpreted as heartburn, or maybe even from a stress situation that difficulty breathing is a very stressful, it provokes stress in itself, and that could lead to, say, heartburn. So they may complain about the heartburn, but you notice that they're kind of short of breath, and you say, well, I see you look a little short of breath. Oh, well, I'm always like this. Hiccuping or chronic cough as well. So then we would ask about personal health history. We might want to ask about previous respiratory problems that they've had, any chest surgery or trauma, if they have allergies to specific things, or a lot of people say, yes, I have allergies. Every spring I have allergies. Okay. Uh, and then they also, if they take any medications that affect their breathing. And those medications could include, say, an inhaler, but they could also include oral medications, or a number of different medications might affect breathing. We'd also want to ask if they've had any chest x-rays recently. What did those show? If they've had any tests for TB, for tuberculosis, and what did that show? Some people will test positively on some of the tests, like people from, in many countries there's a vaccine given that's not given in the US, but there's a tuberculosis vaccine given that makes you react positively to the skin test. So particularly Mexico, the Philippines, and probably some other countries too, everybody gets this BCG vaccine for TB, and so they react positively to the TB test. It used to be that you had to get, if you if you were working in nursing and they needed to screen you for TB, you'd have to get chest X-rays. Uh, but now there is a blood test that can be done every year to see if you have active TB if you react. Uh, you'd also want to ask about immunizations, specifically for influenza, for pneumonia. We Anybody that works in healthcare will get the influenza vaccine every year, and then the pneumonia vaccine is recommended for people over 50, for uh, people with chronic disease conditions, even if they're not over 50. But that's not every year, that's like every 5 years or so. Uh, you'd want to ask about travel outside of the United States for various things. For TB risk, because there's many places, and even in the US there are areas where there's a lot of TB, but particularly if you traveled outside the US to areas where there is TB. And then there's also other similar type respiratory illnesses such as coccidiomycosis. That's prevalent in Texas, Arizona, places like that, but not so much in other parts of the US, and it's also prevalent in tropical countries. As far as family history, you would want to ask if there's any smokers in the home, because secondhand smoke is a risk factor for COPD and for lung cancer. And you'd also want to ask any family history of pulmonary illnesses, especially asthma, emphysema, or lung cancer. Then, as far as lifestyle and health practices, ask about the typical diet, smoking, if they smoke now, if they ever smoked, any environmental conditions that affect breathing, and other exposure to secondhand smoke. Maybe they don't get it in the home, but they work in somewhere where there's smoking going on. And if they have a respiratory problem or respiratory complaint right now, is that respiratory problem affecting their ability to work, their ability to perform activities of daily living? Uh, is it causing them stress? So they appear to be stressed. And also, are they using any herbal medicines? Some of those herbal medicines can have respiratory effects. They may contain theophylline, which is actually given as a respiratory medication, but some of the herbal caffeine also affects breathing. So a lot of caffeine may affect it, but some of the herbal medications include theophylline, caffeine, things like that. Risk factors for COPD include both cigarette smoking and secondhand smoke. Another one that it's not so common here, except with very old people, but women that spend years cooking over open fires will often have COPD. Uh, and maybe 70 or 80 years ago, it was common to have wood burning stoves here in the US, and so there used to be a lot of women that would get COPD from cooking over those kind of stoves. But also in other countries, in some cases it's common to cook over wood or charcoal, and so women that do that a lot of times will develop COPD when they've never smoked, never really been exposed to secondhand smoke, but they got a lot of smoke from the cooking. Um, it's the age where you're likely to start getting it, 35 to 40, and once you get COPD, it's lasting damage. So it's going to be you're going to find a lot of COPD in people over that age as well. Another risk factor is occupational exposure to dust and to certain chemicals. Then, as far as risk factors for lung cancer, again, smoking tobacco, particularly cigarettes, because cigarettes are inhaled, where pipes and cigars, hookah, that typically is not inhaled, so it's less risk of lung cancer, but there is some risk of lung cancer from those forms of tobacco as well. And then the secondhand smoke, of course. Then exposure to asbestos, that was commonly used in building materials until the 70s, I believe. And so anybody that, say, works on old houses or old buildings would probably be exposed to asbestos. Radon is a radioactive gas. It's invisible, no smell, colorless. So you may even be exposed to that without knowing it. Arsenic, and then diesel exhaust. So a diesel mechanic could be at increased risk of lung cancer. Certain types of silica and chromium. Radiation. And then a personal or family history of lung cancer. And then there's some evidence that if you are a smoker and you take beta carotene supplements, those increase your risk of lung cancer. So now we're turning to objective data. And we start with inspection. And typically, in the book anyway, it talks about starting posteriorly. I think that would be the case if you're seeing an ambulatory patient. Usually, if you're seeing a patient in the hospital, you would start looking at anterior with them laying in the bed and then have them sit up and do the posterior inspection. But anyway, I kind of mix the two up together in the lecture, but in the book, the procedure, they start with the posterior and then do the same things anteriorly. So first thing you would want to look at is, how does their breathing look? Do they look like they're having any difficulty breathing? And you say, well, what would indicate difficulty breathing? Well, for one thing, nasal flaring or pursed lip breathing. We teach them to do pursed lip breathing to make it easier, but they actually, a lot of them do it just by instinct, and so you'll see some pursed lip breathing. Also look at the quality and pattern of the respiration. We'll talk about different respiratory patterns in a later slide. But these are things that you see immediately when you first walk in the room. Then you'd also note the color of the lips, face, and chest, and it could be maybe pale or maybe cyanotic, or if there's any ashen gray or whatever. What do they look like? And then color and shape of nails, the famous clubbed nails, which are caused by prolonged periods of hypoxia. And then if you're looking in the front, look at their intercostal spaces to see if there's like retraction or bulging or retractions. This would be especially on infants, but sometimes you'll see it on very thin uh, adults as well. Then, if you're looking from behind, you'd look at the scapula, and are they symmetrical? That would be an indication of scoliosis if they're not. If they're in the front, look at the sternum. It should be midline. It shouldn't be retracted or anything. And then the slope of the ribs, and then the is the if it, then look at the anterior to posterior ratio. So think about if you were going to stab a person front to back, you'd get a certain amount of blood on your sword. And then if you were to stab them from the side all the way to the other side, you should get about twice as much blood that way as you would stabbing them from front to back. And that would be the normal situation. But with a COPD patient, sometimes that can be 1-to-1 instead of, well, anterior to posterior AP to lateral ratio would be 1-to-2 normally. In other words, you're one half of this distance from anterior to posterior, and then the distance from one side to the other would be twice as much. But in the case of a COPD person, it approaches just 1-to-1 instead. Observe for use of accessory muscles. Do they, and that's where they really look like they're struggling to breathe. You say, well, she looked like she was struggling to breathe. How did you know? What was she doing? And then when you think about it, it's those they're using those accessory muscles. You probably just recognize that she's struggling to breathe, but you can't say why. But when you look at it, it's those accessory muscles that are that she's using. Then you may see the person in the tripod position where they're leaning forward using their arms and they're forming a tripod. That's a very classic position for uh, somebody that's having trouble breathing. So then we're going to do some palpation, and whether you're in an anterior or posterior, you'll palpate for similar things. You'll palpate for tenderness, pain, warmth, characteristics of the surface. And then crepitus. What on earth is crepitus? Crepitus is a crickly feeling of the skin. It's caused by air being trapped in the subcutaneous tissue, and it's kind of a crunchy, crickly feeling of the skin. Then also palpate for fremitus, and the book recommends using the heel of your hand for that because it's a vibration that you're feeling for. You have them say 99, 99, keep repeating 99, and you palpate in systematically over the whole chest. And you're mainly, there are going to be some areas where you'll feel some vibration, but what you're really looking for is an asymmetry where if you feel, oh, this is a lot of vibration here on this side, and then you go to the corresponding place on the other side and it's much less or not at all, why that would indicate that you probably got an area of consolidation where you felt the vibration. Then we're going to assess chest expansion, and we do this in a couple of ways. uh, we can have them have them stand behind them, or if they're in the bed, you have them sitting up and you get behind them. Put both of your hands on the posterior chest with the thumbs together at the level of T9 or T10. You've got a little tiny skin flap of theirs in between your two thumbs. Then you ask them to inhale and let your hands move with the chest as it expands, and you should have a movement of about 5 to 10 centimeters. That would be the normal chest expansion. We'll do percussion. So the normal sound that you hear when you percuss over lung is resonance. If you're percussing in the intercostal spaces. So you should hear resonance, that's normal. Hyperresonance would indicate hyperinflation, like say in the case of emphysema where some of the alveoli have formed blebs, and in other words this is open spaces of air as opposed to the alveoli. If you're over the bone, say if you're over a bone, like say the sternum or whatever, well, you'll hear flatness. Flatness is normal over bones. And then you hear dullness over solid organs or over areas of consolidation. So you just percussed to see that it was resonant where throughout the lung field. And now we're going to test the diaphragm excursion. We check chest excursion by feeling how much the chest expanded, how much our thumbs separated. So now the diaphragm excursion, you'll have to percuss for where the tone changes from resonance to dullness, because when you get past the diaphragm, you're going to be over liver, and that's supposed to be dull. So to practice it, I would suggest before you practice it on a person, just practice going down and seeing where, trying to hear that change from resonance to dullness. Do that a few times. So then you're going to have the person breathe out where their lungs are empty, and do that, and then mark where do the percussion to see where that change occurs, and you're going to mark that spot with a marking pen of some kind, an erasable marking pen. Then you ask them to breathe in and hold their breath that way with their lungs full, and do it again. And there should be at least 3 to 5 centimeters of difference between the two marks. And if they're extremely well conditioned, there could be 7 or 8 centimeters. So finally we're going to do auscultation. And in the book they talk about a number of auscultation sites. We aren't going to actually use all of those sites. If you were doing a very thorough respiratory assessment, you might use all of the sites they recommend, but you have to do each one for a full respiratory cycle, meaning they have to breathe in and breathe out, and then you do the same thing on the other side, going from side to side, comparing one side to the other. So we're only going to do in the lab, we'll only do 3 places on each side anteriorly, 2 places on each side laterally, and 4 on each side posteriorly. So we won't do all the sites that are mentioned in the book. There are 3 different normal breath sounds that you're going to hear, but they're only normal if you hear them where you're supposed to. And the areas of the bronchial breath sounds, bronchovesicular, and vesicular breath sounds. So if you hear a bronchial breath sound where you're only supposed to hear vesicular, then that's not normal. It's a normal breath sound. It's normal to hear bronchial breath sounds over the bronchial area, but it's not normal to hear them over the vesicular area. So look at the diagrams in the book to see where those areas are. Adventitious breath sounds, on the other hand, those ones are abnormal anywhere. You don't want to hear those anywhere. And those include crackles, wheezes, pleural friction rubs. And then there's other descriptive variants. Crackles, you may see them also referred to as rails in some books, and wheezes you may see referred to as rhonchi in some books. Then we'll also take the stethoscope after you've listened for breath sounds. You probably will have to tell the person to breathe deeply, unless they're, some people you can hear it just when they're breathing normally, but most of the time you have to tell them to breathe deeply. And you want to listen for the complete cycle, inspiration and expiration in each place, then go to the next place and go systematically from side to side. So then we'll test for three other things: bronchophony, egophony, and whispered pectoraliloquy. For bronchophony, you ask the person to repeat 99 and you listen at the auscultation sites. You should not hear it, should hear something like 99 but not very distinctly. If you suddenly hear it distinctly in a spot, that could be a sign of consolidation. Another variation on the same idea is egophony. You ask them to say E, and the normal, you would just hear it as E. Abnormal, you would hear it as A. And then whispered pectoraliloquy, you ask them to say 1, 2, 3, and you should hear muffled tones. The abnormal, indicating consolidation, is if you hear it distinctly. And once again, you're mainly looking for an asymmetry from one side to the other. So the normal breath sounds, this is how they're defined here. You really have to listen to them though to appreciate them. But the bronchial one is going to be high-pitched and harsh. It'll be loud, and it'll be very short on inspiration but long expiration. Bronchovesicular is kind of between the bronchial and vesicular. It's a moderate pitch, moderate quality and loudness, and the inspiration and expiration will be about equal. And then vesicular is low-pitched, breezy, soft, and it has long inspiration and a short expiration period. So practice listening. There are some sites on the websites where you can go and listen to them, but then practice listening to these on your partner. Try to hear the differences between them. Adventitious sounds, hopefully you will not hear these on your partner, but there are again websites where you can go and listen to these. And so crackles indicate that you've got fluid, whether it's a situation of CHF where there's where the blood is backing up and you've got fluid from that, or if it's exudate from pneumonia or something like that. Crackles would indicate fluid. Wheezes, on the other hand, indicate a narrowed airway. They're more musical. Crackles They say the best way to hear something like crackles is crinkle your hair together in front of your ear. Wheezes are more musical, although some of them don't sound very musical at all to me, but they're kind of they're more of some of them do sound quite musical, but most of them don't sound pretty ugly, like ugly music or something. Then friction rubs occur when pleura is inflamed and it rubs against each other. Uh, so it sounds like two things scraping against each other. It sounds exactly like what it is. So now we get to breathing patterns. Your normal breathing pattern is 12 to 20 regular breaths in 1 minute. The breathing is regular and that's a normal pattern. Tachypnea, it's still a regular pattern, regular breaths, but it's like increased 24 breaths per minute and shallow. Now, if the person just finished running, it can be normal for them to have a tachypnea. But if they're at rest and they have tachypnea, then something is going on. Bradypnea is less than 10 breaths per minute and also regular. In hyperventilation, we have increased rate and depth. That would be the person that just finished running, actually. But when hyperventilation, remember when we were talking about the fight and flight mechanism where your boss is coming scowling and starting to go off on you and you can't run and you can't fight and you just maybe start to hyperventilate. Your rate increases and your depth increases and you start getting dizzy because your CO2 goes way down and your acid base balance gets off. And if it gets bad enough, you may even end up in the emergency room. And they just will probably, well, the old home remedy, which we don't do anymore because it can be a little bit unsafe, but the old home remedy was to have the person breathe in a paper bag, and that increases their CO2 enough to where it breaks the hyperventilation. It works, but it's not recommended to do anymore. Then Kussmaul breathing is a pattern that's rapid, deep, and labored, and this one is characteristic of diabetic ketoacidosis. So if you see that, why then see if there's any acetone. If they look like they may behave like they're drunk, but they're not. Sometimes it gets mistaken for being drunk when somebody in diabetic ketoacidosis. And but the Kussmaul is characteristic of that state of diabetic ketoacidosis. Then hypoventilation is respiration with a low rate and low depth, and it's irregular. There's a specific kind of respiration called Cheyne-Stokes, and this one you have deep periods of rapid breathing that alternate with periods of apnea. And you see this in people that are about to die, sometimes, depending on the mechanism of death, but it's severe CHF in a drug overdose, increased intracranial pressure. I'm sorry, CHF is congestive heart failure, and then severe renal failure too. Then biorespiration is an irregular pattern with varying depth and rate. It has periods of apnea, and it's characteristic of meningitis or brain injury. And then if that becomes more extreme, it's called ataxic respiration. And finally, air trapping. That's where the person they can't exhale as much as they're breathing in, so their chest becomes increasingly over expanded, and they can't breathe out. They have difficulty exhaling, and that can happen with COPD. Some of the nursing diagnoses we'll use, the two health promotion ones I put down here: readiness for enhanced breathing patterns. Well, maybe the person has some COPD or something, but they want to learn about how to care for themselves, or readiness for enhanced health management. Risk ones: risk for respiratory infection related to. Well, what could it be related to? Well, one thing would be maybe if you're living in poor conditions and there other people around you have respiratory infection, like say if you're living with people with tuberculosis, that would be a risk for respiratory infection related to close contact with somebody with tuberculosis. But there could be a lot of other things. It could be maybe poor nutrition. Uh, it could be refusal to take the influenza vaccine. So there could be a lot of things that put you at risk for respiratory infection. Another one: risk for activity intolerance related to, say, COPD. Uh, in COPD, sometimes you get to the point where you can only, say, walk 100 feet, and then you have to rest because you're out of breath. So that person would be at risk for activity intolerance. Risk for ineffective health maintenance related to COPD as well. Then actual nursing diagnoses. And then remember, these ones have to have related to and as evidenced by. So anxiety related to hypoxia as evidenced by patient behavior. The behavior is what tells you they are anxious, and you think that the hypoxia is the reason for that anxiety. Activity intolerance related to decreased lung reserve as evidenced by tiring quickly. You see that your patient gets tired quickly, and you can also see that when they do, they're increasingly short of breath because they got up and walked further than they can, or they tried to strain to do something that is too much for them, and you know that they have COPD, or that they have pneumonia even, and so their lungs are filled with fluid, so they don't have that lung reserve capacity, and so that would be your nursing diagnosis. Now, be careful what you put where, because sometimes students will put they'll mix up, like they'll put activity intolerance related to tiring quickly, and then they get, oh, as evidenced by, what is it as evidenced by? Well, patient reported it. Well, it's like but be careful about what you're putting where in the nursing diagnoses. Then the big three here are at the end, and these ones you're going to be using a lot. And just about any person with a respiratory problem will have one of these as the predominant one, and they'll probably have some of the other two as well, but or at least one of the others, and maybe both. But be careful about which one you choose to choose the most important one for that situation. So the first one is ineffective airway clearance. That's the person that has secretions that they can't get rid of. Their airway is blocked and by all these secretions. Ineffective breathing pattern is the person that either is hyperventilating or hypoventilating, or something is wrong with their breathing pattern. And then impaired gas exchange is the person that say uh, is full of they have CHF and they're full of fluid, and so their alveoli, you can't get gas into the alveoli, or maybe they knocked out half of their alveoli, and so they don't have the alveoli and they don't have the reserve. So impaired gas exchange is a problem at the alveolar level. So select when you're doing a care plan, be careful about which one of those you select. Think about what is really going on here and be careful about which one you select. Then collaborative problems and referrals. There are a lot more than this. I just chose 5 that looked interesting. So these are things that you might find and want to report to a physician for collaborative, or to a respiratory therapist. Risk of complications, atelectasis. You might see some beginning atelectasis and say, oh, this patient didn't have atelectasis before surgery, but now due to the surgery they're not breathing deeply because it's painful. They're not expanding their lungs. They had irritation from that endotracheal tube and from the anesthesia, and so they're developing some atelectasis, and we'd better get on this right away and start doing some things to prevent it from getting worse. Risk of complications, pneumothorax. This is something that you could see potentially, like you could perhaps come in and say, I hear breath sounds on this side, I don't hear them on that side, and it looks like their trachea is beginning to shift a little bit. I wonder if they're having a pneumothorax and they're having trouble breathing. And I think I better get some help quickly, because we're going to need to get a chest tube, and I can't put chest tubes in. Pulmonary embolism, likewise, that's a problem you could see. You could see that in somebody that didn't have that before, and your troubleshooting could save a life. And with this one, pulmonary embolism is a lot of times you may have somebody who has chest pain, and it doesn't seem to be cardiac related, and they're also short of breath. It could well be pulmonary embolism. Pulmonary edema is another thing that doesn't always, you may not be told, oh, this patient's in pulmonary edema. It's like, oh, well, they got too much IV fluid, they got their blood too fast. They can develop pulmonary edema where they didn't have it. The physician came and saw them in the morning, and then at 12 noon you're seeing, well, they're short of breath, what's going on? Oh, I hear crackles in the lungs, and then I hear at the bases, I hear the breath sounds are absent, and and it's getting worse too. So that could be a situation of pulmonary edema. And finally, risk of complications for asthma.